gentlemen, I have great pleasure to introduce a very close friend of mine, Dr. Sameer Mehta, who nobody needs an introduction in India because he is the person who has done the maximum work for STEMI in the United States and created the systems of care, which he started off in Miami, Florida, at the SEDAS Medical Center, and has now propagated this whole concept of STEMI management all over the world through his foundation, the Lumen Global. To introduce Sameer is a great pleasure of mine. He's Associate Professor of Medicine at the University of Miami, School of Miami. He has been a proctor for coronary stenting, DCA, and laser angioplasties, taught angioplasty in numerous countries, and has more than 200 scientific publications. His passion, and you'll see it in his lecture, has been his work with STEMI, and mainly on short door to balloon times that he asserts is the finest indication for PCI today. He's also credited to have the largest single experience of STEMI treatment in the world, and he's a course director of Lumen Global, the world's largest STEMI meeting, which has held its 20th anniversary meeting in India. His recent interests, which he was just talking before this meeting, is in telemedicine and artificial intelligence, especially for EKG reading of STEMI. And I think you will have no better person to talk about STEMI than Sameer. So with this few words, can I ask Dr. Sameer Mehta to give his lecture on STEMI interventions?
Thank you so much for your Dikshit, are you able to hear me?
Yes, sir.
Okay, wonderful. Ajit, thank you so much for your kind introduction, and congratulations on your magnificent presentation on the STEMI in the young population, a topic which is so important because the management is so totally different than our regular STEMI patients. I can tell you that in Miami, I call these patients my Saturday night specials. That is how these patients present, a lot of them with the use of cocaine. My only caveat would be that whenever you are planning to treat these patients primarily with aspiration thrombectomy, that be careful that in the process of doing atherectomy, do not cause an intimal dissection because that will require a stent. Dr. Patel, my congratulations to Intus for creating a magnificent cross-connect program, and I wish you good luck. It was also a pleasure to hear about the ASHA program. Congratulations, Dr. Uni Krishnan. To the audience today, I think we are in a unique position in our lives which truly illustrates why we became physicians. I have recently written an editorial where I call the doctors in 2020 as the soldiers in the COVID arena. But I express my gratitude and good wishes to all of you. But please stay safe. We have several additional burdens, not only to take care of the suffering humanity and the incredible amount of patients who are suffering, but also the responsibility of safeguarding our own health and not bringing the virus to our family, which is making so many contributions to let us perform our job. So good luck to all of you and be safe. Now, in my topics today, Dr. Mulasari alluded to telemedicine and artificial intelligence. I can give you a big message right here is that all the almost 21 years of work in STEMI interventions, I have completely moved away from the concept of door to balloon time. I have always referred to it as the low hanging fruit. I think most countries have achieved it. Several countries, including India, with the wonderful work of Dr. Alexander and Dr. Mulasari and STEMI India, you have impacted door to balloon time. But I do believe that we need to work further now from the door to balloon time to symptom to balloon time. As an example, in India, It's almost 6.5 hours before the patient reaches care of expert center. And I will share with you some work with artificial intelligence, how we can start impacting not the door to balloon time, but going even further, symptom to balloon time, because it is truly not a door to balloon time, but the true ischemic time which makes a difference. So hopefully we'll be able to share some of the work with telemedicine and artificial intelligence. I thought I would discuss three topics today. Of course, any lecture or deliberation today without talking about the COVID aspects of STEMI would be incomplete. There will be the major body in telemedicine and artificial intelligence. And of course, as I was provided the responsibility of looking forward, what is the larger message through this superb cross-connect initiative, what are some recommendations and looking forward for India. So this has been the proud privilege in life to have taken the work of Lumen Foundation globally. And when I look at it, several years, 2 decades later, and I look at it, my overwhelming message is exactly the same, that we need to continue reducing the disparity between the developed and the developing countries. We need to reduce the disparities between genders. Women present much later. I think that's an area where tremendous improvement can be made. But the absolute overall theme, as I'm looking at these 30 countries, I can tell you it is time for us to move away beyond the door to balloon time to the symptom to balloon time. And I'll share with you how artificial intelligence can provide a tool for a self-administered tool, how a patient can immediately make an accurate diagnosis of STEMI. And now you're able to truly make a difference and impact both the acute and the short and the long-term outcomes. So a couple of thoughts about COVID STEMI. We immediately went into a crisis mode as COVID started affecting New York City. I do a lot of work together at the Mount Sinai Hospital there. The entire hospital went from a multi-specialty top global institution to a STEMI care, to a COVID care within a matter of days. The lobby of the hospital had to be converted for ventilated patients with COVID. And immediately our reaction was that, look, we need to start considering thrombolysis, because that would safeguard the healthcare providers. We knew there were going to be system delays, and thrombolysis appeared a good initial therapy. And even we were contemplating and debating whether even patients need to be transferred from non-PCI institutions and get thrombolysis at site. But almost, I think it took us less than 2 weeks to realize that primary PCI still remains absolutely the right way to
Dr.
treat
Sameer,
the COVID.
sorry to interrupt you. Sir, we are not able to see your slides. Have you shared?
I have been showing my slides all this time, and I had pressed hold on 1 second. Let me know if you are you seeing them now?
No, sir. Yeah.
Now you're seeing it?
Yeah.
All right.
If you
So,
can do it in full.
Go back to
full screen mode.
I will, and here you go. Let me know if it is okay.
Yeah.
So we haven't really missed much. This was the previous slide I had showed. Sorry once again. These were the three topics we are talking about, and here I am mentioning that primary PCI still remains, I think, the ideal treatment because of the coagulation aspects which are occurring in COVID STEMI. probably make thrombolysis a more complicating management. Some other aspects, I think COVID has truly flattened the disparities. I'm performing STEMI today like how I used to do in year 2000. Patients are presenting 4 hours, 5 hours late, and it looks like all the gains which we had in 20 years are gone. It's also that when the patients are presenting later, you're dealing with a more complex procedure. The patients are sicker, already in pre-shock, and geographically you're dealing with dense organized thrombus. So we've had to really look back into how we were treating and managing this before. Just if there are any interventional cardiologists in the audience, I can tell you that 2 or 3 major differences in the STEMI procedure. We have reverted back to doing a lot more femoral access because you are a little further from the patient. I think one of the simplest recommendation is as soon as the patient is being transferred to the cath lab, we ensure that the patient himself has a mask on. Sometimes that was missing. And of course, we were getting a rapid COVID test in all of them before they were moving to the cath lab. However, we realized that also is not a foolproof strategy since almost 35 to 40% were false negative. So far as the procedure is concerned, I have also noticed that majority, in fact, 72% of the lesions were in the right coronary artery for whatever reason that is, and that there is far more diffuse spasm, and that a lot of these patients tremendously benefit just from the use of intracoronary nitrates. But enough about COVID STEMI. Let us talk about the larger aspects now. If you hear from Dr. Uni Krishnan's work and the work of STEMI India, in many ways, that is telemedicine. In the United States, everything, if you look at it over the last 3 months, one of the things the COVID experience has taught us is how totally medicine will be transformed. I think with the COVID crisis, it seems to be clear to us, at least in the US, that how and where the patients are going to be seen is going to be dramatically changed. Whether it is going to be changed with telemedicine, aspects of virtual monitoring with artificial intelligence, only time will tell. But this is the power of telemedicine, what you are able to do today. And on the right side, you're seeing 4 countries where I have created the Latin telemedicine program. You could easily put the map of India. Why I am emphasizing so much on this work, and Dr. Uni Krishnan, this is ASHA times 10,000. That is what it is. And to Dr. Mulaseri, this is STEMI India times whatever it is. It is exactly the same concept. But here has been an opportunity over the last 10 years to demonstrate covering 100 million patients in 5 countries and managing their STEMI remotely. If that can be done, I am sure parts of Southeast Asia, parts of countries, parts of the world with disparities can be affected. And let me tell you how exactly this is a single standardized protocol which we imposed on the entire 355 centers in 5 countries over a decade. Didn't change at all. With telemedicine, we are able to do 2 things. We immediately diagnose the EKG and then triage the patient either into thrombolysis, pharmacoinvasive management, or primary PCI. When we started this program, there is a city of Barranquilla in Colombia. We ran a test pilot there. 76% of the patients were self-transporting. So what is it? That is India. That is exactly how things are happening. And 5 years after the program had been launched, 82% of the patients were now coming earlier, coming via ambulance. And this is one of the things which we can benefit and imply in India. Now, this is what I call the navigational map And this is the country of Brazil, probably 2.5 times the size of India, a population of 240 million. I believe they probably today have the highest incidence of COVID. Also because I think there has been, although the number of cases are dramatically increasing, I think the numbers of undiagnosed patients may even surpass the ones in the US. But irrespective, going back into how we created this hub and spoke strategy, here is the entire nation of Brazil, and we have the centers located in about 17 cities, hub and spoke model. This navigational plan tells you exactly how much is the distance between a hub and a spoke. Often the average was about 180 kilometers, what kind of therapy was used, what resources were available for ambulances, the telemedicine encounters, the STEMI diagnosed, the STEMI treated. And one of the things which we were able to achieve, and I'll demonstrate to you in this slide, this is known as time to telemedicine diagnosis. When we started this program, we had exactly the same problems which you would experience should you be starting this program in Gujarat or in Haryana or in remote parts of the country, that initially there were challenges of technology. We were struggling with the broadband internet capabilities, and we realized very quickly that the more investment we were putting in getting the technology sorted out, and particularly the use of cloud computing and some incorporation of business intelligence tools, our time to telemedicine diagnosis, this is a new parameter. Any of you working with it, should that be with the STEMI programs, even parts of what Dr. Unikrishnan mentioned about the ASHA program, there have to be some parameters of measuring it, and we created this time to telemedicine diagnosis. There are 8 aspects how an EKG is diagnosed, how it is acquired, how it is transmitted, how it is received, the artifacts are removed, the cardiologist is immediately found, he makes a diagnosis, and 3 alerts are passed on to the hub, to the spoke, and to the transport center. And the telemedicine, time to telemedicine diagnosis, which used to be about 27 minutes, at the moment is 3.5 minutes. Now, hear this out, and I'll tell you the relevance why I decided to spend a few more moments on this particular slide. Now, we had 2 models in Latin. There was a model where both the telemedicine center and the STEMI center were in the country. That happened in Colombia and Brazil. So all the 104 centers in Colombia and 185 centers in Brazil were diagnosed through telemedicine centers located there. However, for the country of Mexico and Argentina, the centers were outside the country, and the time to telemedicine diagnosis in both was 3.5 minutes. What does it tell you? This is the power of telemedicine to flatten the disparities. If I am able to reduce or have the same time monitoring patients in Mexico from Colombia, I can do the same from Miami and Zambia or in any other country. That is the power how you're able to provide, particularly when you're dealing with the conditions which are so time dependent. And the 2 I'm talking about are the biggest killers of mankind, number 1 and 2, STEMI and stroke. These are some of the results which we were able to do. Significant reduction in door to balloon times and mortality. The cost effectiveness of the program, we compared it. There is nothing you can compare Latin with. We treated almost a million patients, impacted a population of 100 million patients. And the only thing comparable to it is something which was able to use 9,000 patients in the United States. The cost savings are tremendous. We even did economic forecasting where in year 2026, almost 42,000 patients would be treated after 80,000 being diagnosed, and the saving of almost $281 million. So not only with telemedicine are you able to save life, it is cost effective, as once again, Dr. Unikrishnan had shown how they are able to make a difference, I think. So what is the relevance? What is the relevance of this telemedicine program? Why did I decide to choose this topic for Cross Connect? I think the Latin program provides a global template, how we can take care of patients in poorer parts of the world and how we are able to flatten the disparities. I also believe that it can become a population-based management for other conditions, mainly stroke. And of course, I'll talk to you about artificial intelligence. So this is the RAHAT program, the Rajasthan heart attack treatment program, now ongoing for about 3 years. India's most populous state, and here it is. It is truly a sophisticated, cost-effective copy and paste of the Latin program, and several publications will be coming out of it. And so this is the contribution of telemedicine, the lessons learned from India, applying it to where it is needed most, and here it is for Rajasthan. This is what we have done with Mexico, and partnered this with their national interventional cardiology program known as SOCIME. Now here the partnership was very unique. And Ajit, these are some of the models which I think could be used for STEMI India. Here we collaborated with the national societies and have completely clear role. Latin was responsible for the active program, how we were using the hub and spoke strategy to get the patients to reduce the times and to improve the outcome. Whereas SOCIME with their Código Infarto program was the educational arm, which I think is as important. So as an example, the initiative you took with the STEMI India and CSI is precisely the same. There is an arm which has a expertise in guiding STEMI management, and a much larger footprint of organizations like SOCIME in Mexico or CSI in India, which is able to spread the message of awareness. So this is, now we have started converting several of the Latin heart attack centers to stroke. And once again, the methodology is simple. The intent being that we can perform in 2020 both heart attack guidance and stroke guidance without a physician. This is some of the work with artificial intelligence. I'm presenting about 7 papers on this particular physician-free triage of heart attacks and stroke at the European Society of Cardiology. And I shall be sharing, hopefully in a future Cross Connect program, more details on that. How you're able to do, you're basically superimposing. You have to realize that the management of stroke in many ways is exactly the lessons which we have learned with the heart attacks, just that we are, I think, several years ahead, and we have figured out exactly what is a comprehensive management. But gradually and quite rapidly, at least in the United States and Europe, a lot of stroke centers are being created, as well as some centers which we call a comprehensive stroke center. The methodology and the purpose why I'm sharing with you is very simple. If you are in a city, in a community, in an area where you are contemplating telemedicine for STEMI, you might as well take the next step and use it for stroke also, as we are using it in the Latin program. Attack 2 pathologies, similar pathogenesis, similar management strategy, similar processes, similar emphasis on early management, early detection, similar use of ambulances, and of course the application of telemedicine and artificial intelligence. My last topic here is that we have also created artificial intelligence tools. This is an area for almost last 5 years. 90% of my work has been spent on creating a patient's self-administered single lead ECG for diagnosing heart attack. We've been working with the EU to get the CE mark for this, and we are setting up various FDA protocols to get this demonstrated, and to demonstrate how you're able to, how a patient is able to immediately diagnose STEMI, how it can even summon the ambulance in sophisticated regions of the world. And of course, the intent being that Forget door to balloon time. It is symptom to balloon time. This is not anything different than as Dr. Mulaseri would remember about my presentations in India 15 and 18 years ago. In fact, my first presentation I remember was in Pune, and people used to be saying, you know, how can you talk about door to balloon time? I mean, I was often subjected to even ridicule that, you know, you're coming from another planet, you know, door to balloon time in India. This is exactly what will happen in the future. You have almost addressed door to balloon time. I think the focus should now be on symptom to balloon time. There is no point my driving to the hospital at 3 in the night at 100 miles an hour if the patient was having chest pain, particularly the subset of patients with which Dr. Uni Krishnan deals with, the very large diabetic population in India, very hard to diagnose. Elderly are difficult to diagnose. Women have atypical symptoms. You need to have a tool that you're able to diagnose at the point. And if the patient is able to diagnose that he's having a STEMI and start accessing care, again, it does not eliminate some of the challenges in India. I think this is a modality which we'll be able to demonstrate first in parts of the United States and Europe, and hopefully take it globally. This is how we have used the methodology of a single AVR lead, which is now reaching diagnostic accuracy of almost 90%, 97%, sorry. So as the last vignette, recommendations for India, a nation where so many physicians, I look at it, it's almost like how Dr. Dikshit Patel started the introduction, a glass half empty or half full. So the half empty is that the hardest STEMI, the biggest challenge is in India. There is no doubt. You know, Dr. Mulaseri takes care of patients which are 10 times harder than my patients. You know, 35-year-old patient presenting with multiple risk factors, diabetes, a culprit lesion in the LAD, diffuse disease in other areas, impaired LV functions, much harder than the kinds we deal with. So that's the glass half empty. What is the glass which is full is the just like how you have a 35-year-old patient, you have a 35-year-old interventional cardiologist in India, highly talented, committed people, willing to take call, willing to save the lives of these patients. And I think much work can be done in India. So this is some of the work which I've had 4 Lumen global meetings in India. These are the Lumen Foundation directors, group of very committed people. And we looked at some reasons and some of the barriers in India, and these were the barriers. So don't spend too much time into these barriers and trying to understand. I'll give you the message very simply. Whether it is related to patient insurance, transportation, hospital, physician, technology, it basically means one thing, the process. In India, the STEMI process has to be improved. Your procedure is exactly what you do. Dr. Mulaseri is as, if not more talented than me. It is the process which needs to be improved. And that, I think, is the lesson for India. So in my final conclusions, I think regarding COVID STEMI, go back to primary PCI. Don't spend time in thrombolysis. Best recommendation for STEMI in India is to continue to improve the process. I hope my work with telemedicine has demonstrated to you its relevance in India. And I also believe that it is the way to flatten the disparities in the poor regions of the world, in Africa, in the Middle East and Southeast Asia. I think you can apply the same telemedicine principles to also attack stroke. And I am absolutely convinced the future of STEMI is going to be heavily impacted with artificial intelligence so that we can go to the final symptom to balloon time rather than door to balloon time. It has been an absolute honor. I want to thank Dr. Dikshit Patel as well as the other members of the team for making this possible.
Thank you, Sameer, for an excellent talk. And we have some questions coming in from the audience, and I'd like, some of them are directed to you, some are directed to me. So let me ask the first question to Dr. Mehta. is, should we put so much of emphasis of an exact cutoff of 90 minutes for a door to balloon time at all or not?
What a beautiful question. So we actually came out with two recommendations, one for SCIES, Society of Cardiac Angiographers and Interventionalists, as well as for the Cardiology Society of India. And one of the recommendations is, in the COVID era, do not worry about door to balloon time. This is not your primary target here. Of course, door to balloon time impact early and late outcomes. It's important, but suddenly we have much more pressing uh, issues such as our own safety, the safety of the cath lab team. So, and also again, in the United States, some hospitals like some we have in Miami have become sophisticated, where we are doing COVID testing. The intent being that you take the patient to the cath lab who's truly COVID negative. So in the present year 2020, in the COVID era, door to balloon time needs to be backed away. In the United States, they are being rigidly monitored. We have actually stopped doing it. So don't worry about door to balloon time. You have enough challenges of taking care for the COVID patient.
Okay, there's another question is that what do you think in this era of COVID that you said about thrombolysis not being so effective? Is there a view of a pharmacoinvasive approach at all?
Absolutely.
Or you should go in for primary for all patients?
Right. So this is Ajit. When I made that statement last night, I was thinking of the slides. This is exactly what happens to me when I'm taking a flight to India. On the flight, I'm constantly reminding, don't get too carried away. What works in the United States is not necessarily, or in Europe, is not necessarily true, where you are dealing with issues which are so relevant. The ground realities are different. So please do not take that as an absolute. I think I read between the line what Dr. Mulaseri may be stating, or I would want his comment too. I do believe that in the Indian environment, pharmacoinvasive management still is highly relevant.
Yeah, so I think that what we are now talking about two issues, the COVID and the non-COVID times. The COVID times, I clearly think that thrombolysis may not be that useful because it's an inflammatory process. There is a lot of microvascular problems, and thrombolysis has never been shown to be proven. The challenge of primary PCI is an infected patient in which the outcomes are not very good sometimes because of the generalized sepsis where you're doing primary PCI. But I think I agree with Sameer that, and we have this paper now just put in during COVID times, the approach to MI patients in India and how to go about it. But most important thing is to be safe during these procedures to yourself and to understand that the patients even may have a simple right coronary, but because of the sepsis of COVID and many of these patients being sick, they may not necessarily have the same outcomes during the PCI of a non-COVID time patient. So I think this is very important for us to keep in mind before we jump into. There's a question is, which lead are you using for telemedicine? I understand it was AVR, but which lead are you using for your MI diagnosis?
V2 or V3 is the most accurate.
Okay, so that's the lead that he uses for the whole thing. The next question is maybe directed to me, and that is, in young MI patients, how often do you get away without putting a stent? Well, I think that, as I've said, that we have to be very careful that we don't blindly not stent the patient. You have to clean up the vessels with what you have, with a thrombosuction or a thrombolytic local or a 2B3A receptor, then assess the flow and the lumen size, and then decide whether you need to stent. Because the last thing you want is a reocclusion in a few hours because of the flow being sluggish. So it's not a generalized rule, but we have found that a lot of these patients have plaque erosion and they don't need a stent at all because it's all clot and the endothelium is all that is functional. So what you can do is avoid the stent. We are doing a big study now called Erosion 2 with IKJANG, which is a non-STEMI patient group where OCT will be used for diagnosing residual lumen of less than 1.9 to stent or not stent. So I think this is another important work we are doing to make these patients clear. Now, the next question is, you said, Sameer, that you moved from radial to femoral in the COVID era for safety issues. But in general, obviously, the radial approach seems to be a more convenient, more better and less bleeding way of doing a procedure in general. But in COVID times, you move to a femoral approach. The question is, how does that make sense? From in a
Little, not that much different. Even something like that, we have slightly backed off now. We've learned how to manage these patients much better. The PPE is far better. We are securing the patient better. So yes, no big deal. Initially, when we started doing it, see, you have to realize that. I don't know about you, Ajit. I have done about 27 STEMI during the COVID period, and it has been further lessons in humility about how to deal with the patients. The simple message is, I do not today complete a procedure over just by doing a procedure. I think it has to be done safely so that nobody in the cath lab gets infected, including myself, and bringing the disease to the family. So you have to be whatever in your own environment you have to realize that what is the point you see. Also you have to realize that I think one of the points which Dr. Mulaseri and I should have said is that outcome and mortality of the STEMI COVID patient is much higher. There are these patients who are not doing well. Initially we were getting these 85-year-old patients from nursing homes which were flagrantly COVID positive. We lost the patient, and now you are scared that you may have infected a whole team of 10 or 12 people. So be very careful, and particularly pay attention to your own protection and how, you have to realize that it is now takes me a ridiculous amount of time, discipline, and preparation to walk back into my own home. So there is a methodology how I initially used to prepare myself for reducing door to balloon time. There is the same discipline which is now required how I come outside, change my clothes, take everything off, go straight from the garage, take a shower, scrub myself. So some of these things are important. So between radial and femoral, if you feel more comfortable with the radial, of course, I don't think there is much of a difference.
Okay, so what about low molecular weight heparin and anticoagulants in the era of COVID because of the issues of pulmonary microvascular coagulation and issues in the microcirculation of the coronaries? Do you use that? Because normally during a usual PCI, it is just antiplatelet therapy. So do you use anticoagulants?
Well, I have been a big proponent of bivalirudin. I have not changed that much. The use truly has been a very early initiation of dual antiplatelet therapy, definitely initiating ticagrelor, which has been my preferred treatment for the last many years, and of course bivalirudin. The real difference I can tell you I have noticed is that the thrombus is much more profound, more diffuse, more dense and organized, and there is a far more coronary vasospasm. In fact, there were 3 particular patients presenting with classical STEMI, and I think they were younger ones, which was all diffuse vasospasm. I took a look at it. One was a 95% proximal LAD, another was the right, and all it needed was nitroglycerin. And so just to watch out before you immediately chase the lesion. In fact, I have made it a regular practice now. I give 200 mics of intracoronary nitroglycerin before making any rush decision on the STEMI.
So there's another question as to has the patients of ACS dropped all over in the US, just like
what a lovely question. So Dr. Sameer Sharma and I recently wrote a little editorial about some of these, and the debate is open. I'll give you the consensus of the document was exactly what Dr. Mulaseri said, that the cases have gone down. My own personal feeling, in fact, my cases have stayed the same. If anything, they are a little higher. I think it was the fear factor. It was the fear factor that the patient was absolutely so frightened to go to New Delhi. I speak each day to my mother in New Delhi, and I can tell you, if she was to have chest pain, I would manage her MI with beta blockers at home rather than let her go to a hospital.
Yeah, so basically, I think STEMI patients ACS patients did come down all over the world, but what we need to understand is one was the fear factor, sometimes accessing ambulances and transport, especially in countries like India, where as such the ambulance services are a bit difficult to get. And finally, the most important thing is that we found that the young MIs again dropped quite significantly during the COVID times. And maybe one reason is apart from the patients not coming to the hospital and accessing the amount of smoking, cigarette smoking in India is not much at home. So when you sit at home, your cigarette smoking comes down, and maybe one of the risk factors for young MI is smoking, maybe a lower. The
And on the same area, I think the impact of pollution too.
pollution too has come down. The particulate matter has significantly come down in Chennai and Coimbatore. We have a paper now just coming into publication of pre versus post COVID times of STEMI and young MI. So I think with this lecture, I think in the time, I would thank Sameer once again for a very nice presentation on artificial intelligence, and hand it back to the organizers for the next presentation by Dr. David Matthews.
Ajit, thank you so much, and congratulations again to Team Cross Connect.
Thank you, Dr. Sameer.